we know around approximately 3,000 species of snakes. Out of them, I think 600 approximately are venomous, mostly found in the tropical hot climate. And common are cobra, crab, vipers, and coral snakes. The death burden in India is around 50,000 per year, whereas globally it's around maybe 20,000 per year. Snake venoms can produce various actions in the body. It may be cytotoxic, neurotoxic, hemorrhagic, uh, procoagulant, nephrotoxic, myotoxic. So it's very important topic for the students, and Dr. Prateek will allay our misconceptions also, which we know. So please, we can start, Dr. Prateek.
Yeah, sure. Thank you, Dr. Nikesh, and thank you, the ICCM STEP program. So I'm here for as the sir has already have given a brief of it. That's very great for sir that he has make my work very easy for digging the epidemiological part. So I just make you part and make you understand things of venomous snake, how they can be managed. So start with the epidemiology. The big thing is that 2 lakhs of snake bites and are seen in India estimates, and 25 to 50,000 deaths are seen overall. Male to female ratio is 2:1 because we males are very apprehensive to do it and what to find it out of it. So it's ratio is more than 2:1. So mostly it's in rural and lower limb to it's mostly the bitten part is the lower limb, which is easily accessible to the upper limb. And the majority of the bites is 80% and are by the non-venomous snakes, and delayed administration of snake venom will be result in high fatality, but in a venomous part, not in a non-venomous part, but it will see in overall consecutive slides. So these are the identification features of the venomous and a non-venomous snake. Is just a diagrammatical presentations. I don't think so it really be valuable. But yeah, triangular shape can be look like a venomous, and a non-venomous look like a rounded head shape. So go towards the poisonous part of it. The India in 236 species and only 13 are poisonous. So mostly we see the cobra is mostly seen, and then a Russell viper and saw-scaled viper and a pit viper. So the in cobra, that's mainly a neurotoxic and a crate. Most of the patients come with a crate of a neurotoxic, and we define it. They come in a ICU. They behave. They have no cuff reflex. They intubated, no reflexes, and we think in a brain dead. But yeah, there is a neurotoxic effect that takes a time to get evolve and get defined to get managed very slowly. So we have to go in a part of very hand to hand and give a time to a crate to so that the things can be easily managed. And the Russell vipers are the hemotoxics, and the soft scale vipers are the hemotoxics. Mostly the hydrophilic sea snakes, myotoxics are very less seen. So these are the very diagrammatic representations of king cobra, crate, and the Russell viper. So the venom characteristics, how the venom when it enters in the body, so how what are the features of it? It's a synthesized modified salivary gland, first of in the snake, injected to a special channelized groove, injected to the groove from the from teeth called the fangs, and complex mixture of proteins including large enzymes and a local tissue destruction. Low molecular weight polypeptide lethal systemic effect, acidic specific gravity of that venom is 1.0330 and 1.070, which is very high molecular weight. So and very specific, it's high. On drying, this fine needle-like crystal which give you a pinpoint and pricking sensation in the body, and it's a water soluble. And lethal dose of the part of venom injected in the body is 0.12 gram if cobra, and grade 0.06 gram, and the Russell viper is 0.15 grams. So this is the point, it's in grams. Okay, so the composition of the snake venom is procoagulant enzyme of a Russell viper, and hemorrhagic is an enzyme which is called a zinc metalloproteinases, damage the endothelial lining of the vessels, and the cytolytic and necrotoxins causes a damage effects in that endothelial lining. Hemolytic and myolytic phospholipids aid to damage cell membranes. This is called the cell membrane part of the skeletal muscles, nerves, and red blood cells. Presynaptic neurotoxins, which is elapidin, some vipers, which act on a presynaptic part, and the postsynaptic part on a elapidin. So the pathogenesis of the venom, hydrophiliae, the poisonous sea snakes, elapidin, cobra, crate, and snakes. Venom have a curare-like effect. So it's like a neurological suppression, causing a neuromuscular dysfunction or a weakness-like effect. And that's why the most of the deaths we see in a cobra or a crate is like a respiratory depression. So neurotoxic venom produces paralysis and respiratory distress by binding the nicotinic acetylcholine receptors, preventing a depolarizing action. So it acts on the nicotinic acetylcholine receptors. So it will not, the depolarization will not act on the muscle fibers. So it will not, the propagation of the nerves fibers or the nerves will not go on. So it will inhibit that effect by the neurotoxic venomous part of the cobra or a crate. Neurotoxin interferes with the neurotransmitter release, cause muscle paralysis, respiratory failure, and death by asphyxiation. So this is the thing that we have to. So these patients have to look for ABC. The airway should be protected as soon as possible as you inquire these type of patients. Crate has a presynaptic action. So it inhibits the release of acetylcholine from the presynaptic membrane. Presynaptic nerve terminals exhibited signs of irreversible physical damage and a divide of synaptic vesicles. So if the release of the acetylcholine will not be possible, so the depolarization will not be occur. So it acts on a presynaptic part. So nerve has a presynaptic and the postsynaptic part. The crate act on a presynaptic part. And as you see, some act on a postsynaptic or the neurological depolarization effect will not occur. So the anti-snake venom and anti-cholinergic effect have no effect because the vesicles are not increasing. The vesicles are not coming out from the presynaptic part. So if you give anti-snake venom, if you give anti-cholinergic, will not give any additional benefit. So it will take its own time when the vesicles start forming, and then the depolarization will occur. In the cobra act on a post-symptomatic part. So it act on the, it inhibit this part, like a non-depolarizing muscle relaxant type. So it act on acetylcholine receptors, it block the sodium channels, so the depolarization will not occur. In type of patients, you have to give anti-snake venom. So what are the clinical features? As every snake bite occurs, its bite is increasing in local pain, bruising, bursting and throbbing pain, local swelling that gradually extends proximally to the bitten limb and then extended to the part. Mostly lymph nodes are very less affected, but if affected, the draining part is getting affected of the lymph nodes. Bites by the crate sea snakes may be virtually painless and may cause negligible local swelling. So that's why it's not easily find it out that patient is bitten up by the snake bite or not, because it doesn't feel anything. They're virtually painless. So it's very difficult to find it out the causes or the effect. So they are very slowly, so they come to the hospital late presentations. So neurotoxic and venoming examination asks the patient to look up, because you have to give the neurological examination. So you have to go all of the cranial nerves, all examination you have to go, you have to do it, like test eye movement for evidence of early external ophthalmoplegia, check size of reaction of pupils, ask the patient to open their mouth wide and protrude their tongue, early restriction, often due to paralysis of pterygoid muscles. The muscle flexing the neck may be paralyzed given the broken neck sign. So it is so much paralysis can occur. I think I'm not going fast. Is Eddie, everyone audible? Am I okay, sir?
Yeah.
Yes, fine, sir. Fine. So these are some features of a neurological manifestation we see in a snake bite of a cobra in a crate. So neuroparalytic snake bite of patients present with typical signs and symptoms of 30 minutes of 6 hours in cobra bite, but 6 to 24 hours in crate bite. So that's why you have to evident for crate bite 36 hours of hospitalization may be required. You can't send the patient like that. Yeah, the patient does not find, yeah, okay, your patient is fine. Your patient have no neurological deficit. The patient is taking, so that the deglutition is proper. Dysphagia nahi hai, dysphonia, there is no dysphonia. So you have to wait for 36 hours because some features occurs very late. So dyspnea, dysphonia, dysarthria, diplopia, and dysphagia we see every day in the 5 Ds, and 2 Ps we see as ptosis and paralysis. So what is the bulbar paralysis and respiratory paralysis is, can the patient swallow and secretions? You have to see that. So if we acquire that, that's a bulbar paralysis, and you have to intubate the patient. Ask the patient to take a deep breath in and out, paradoxical respirations. If not, then you have to intubate the patients or give the assistance of the ventilation. Objective measurement of the ventilator capacity is very useful. Use a peak flow meter, spirometry, FEV1, FEC. Ask the patient to blow into a tube of sphygmomanometer to record the maximum expiratory pressure. So the paradoxical respiration, how you define the paradoxical respiration? Single breath counts more than 30. If he or she is not able to count more than 30, then it has any respiratory deficit is there. Breath holding time more than 45 seconds, it's okay. Less than 45 seconds, then you have to give an assistance of the respiration. In children's, how you find it out? The cry in a child is very, whether a loud or a husky, can help in identifying the impending respiratory failure. Primarily, the hemotoxic venom. A hemotoxic venom that acts by lysing, which is seized in a viper, by lysing the erythrocytes. Venom of this kind is proteolytic action. So the coagulation will get delayed. The blood is not able to coagulate. The simple thing you have to remember in hemotoxic is blood vessels or the coagulation is not able, or the hemolysis go on in blood vessels. So patients mostly present with a hypovolemic shock. So the local signs and symptoms and signs in the bitten part is fang marks, local pain, local bleeding, bruising, lymphadenitis, lymph node enlargement, inflammation, blistering, necrosis are the other signs and symptoms which can be found in a later part of a course of a treatment during a time. So the hemotoxic bite, bleeding and clotting disorders seen in a viper, as I've already told you, spontaneous systemic bleeding from gums, epistaxis, bleeding into the tears, hemoptysis, hematomasis, rectal bleeding. Patient can present with this if the patient present lately in a viper bite. So these are the things are seen in a bitten parts. The fang mark can be seen or the bleeding can be seen. So these are the features in a tabular format which make you in a simpler way. What are things can be seen? Local pain can be seen like cobras in scenery, yes, and great you can't see. So that's why they be in a delay presentation. Vipers and others, see you can see the pain is there. So and the renal complication is mostly in a viper because they're mostly present in a hypovolemic shock. So renal dysfunction seen in the viper part. Neurological seen in a cobra and crate. So cobra and crate, neurological symptoms. Vipers, hypovolemic shock, renal symptoms I can be seen. So, and the response to neostigmine seen, of course, if there's a neurological, if neurological dysfunction, then we can give the neostigmine to this patient. The patient will respond, or patient will get respond with that. So neostigmine is useful in that. So there are some factors also for contributing the severity and outcome of the snake bite. So one fang mark is not that if the snake bitten, then everyone will get a symptoms. No, there are some factors also, like elderly patients, comorbidity. First, exercise. If you run the bitten, if suppose someone has bitten by the snake, and if he take exertion, if he run, if he walk by himself, then more it will be get circulating more, the toxin will get circulating more in the body. Like, so bite characteristics also. How much deep is the bite? How much, it's a dry bite, it's a wet bite, clothes, it's a bitten on clothes, it's a bitten on a shoe. Okay? And the treatment, when the treatment was taken, the late war treatment or first, how much time it was elapsed from the bitten part, how much time it was elapsed from that part. Okay. So this is the ministry from the snake bite, which give the management also and very helpful for us. So and will guide us how to manage. So first aid treatment, transport to the hospital, rapid clinical assessment, resuscitation, clinical assessment, species diagnosis. Antivenom is the most foremost part. I think everyone knows it. When a snake bite is there, we have to give the antivenom and supportive ancillary treatment with the bitten part, follow and rehabilitation. So the first thing you do, whatever, when you find the patient with a snake bite is carry no right. That is, do not carry the patient for a short distance. You have to support the patient. Rightly reassure him that no worry, snake bite, every snake bite is not venom, is not venomous. You have to give a sometimes non-venomous also. Immobilize. Get to the hospital immediately. If no pre-1 benefit is there, Then also you give the patient hospital management is required. Don't tell the doctor or for any systemic symptoms you find in a course or the way of the hospital. It is very important. You find that there's a ptosis is there, or you find that there's a bulbar weakness there, the patient is not able to speak, then you find that the toxins are acquiring very fast in the body. Okay. So you don't have to like this. You have to be supportive, like a hospital. You don't like carry on the patient like carrying limbs. So you have to take an ambulance. Okay. So this is a right way to immobilize the limb, and which is the beaten part. It's like a when a fractured limb, like a fracture of a limb, you do in a first aid part. Like this way, you support the limb of the venomous the part that is beaten by the snake. So what are the things that you don't do in a first aid? The things that you do in the first aid that I've told you. What you don't do, do not apply the tourniquet, do not wash the bite side with soap and water, do not make cuts, or do not use any fancy things like sucking the blood venom in a old folk talk, what is seeing like out of the venom with your mouth. Don't do that. Do not attempt capture or handle a kill snake. Don't bring the snake with you. Okay, these are the old folk sayings. Don't do it. So this is a very fancy thing that I've added to my slide is on a person doing आपको ये मैसेज दिखते होंगे हमारे यहाँ this क्या निकाला जाता है ऐसा जो काट के आपको काट के these fancy things you don't do it. So what are medical legal things? 39 codes of criminal procedures under constitution of the Indian articles and MLC to be initiated to every snake bite. Okay, whatever the trauma, whatever poisonous thing indulged in your body, you have to go for the MLC. Emergency care. The initial management includes dealing with the airway breathing treatment, like airway breathing and circulation. Every part of management of a critical care. Administer tetanus toxoid. Pain can be relieved with oral paracetamol. Don't give NSAIDs. Emergency care, IV access stabilized by the unaffected extremity. CBC, coagulation profile, fibrinogen concentration should be assessed. And the tourniquet should be removed carefully if someone had applied because the necrosis can occur. If someone had applied, should be removed carefully or should be removed as soon as possible. The bitten extremity should be marked at two or more sites proximal to the bite every 15 minutes to monitor the progressive of the edema. So like you have to see that this, you have to mark it like this way, edema is increasing, like it's proximally or distally increasing. You have to mark the site. So all patients have to give 24 to 46 hours or 36 hours to an observation. Many species, but with crate and hump nose spit viper, have a delayed appearance, so you have to keep it on for more than hours. So most common investigation, I think everyone knows it, is 20 whole blood clotting time. You just simple maneuver, you just take the blood, you put in a glass tube, you keep it untouched for a 20 minutes and you see the clotting time. If it's and you just tilt the slide. If you tilt the test tube and you find out the blood is still thinner, is not coagulated, it means coagulation ability is lost, whatever it's viper or a cobra or a crate. So you have to give an anti-snake venom. But if it's not, if it's beaten by the non-venomous or the patient has symptoms, so you have to give anti-snake venom by any of the investigation part. Okay. So what other investigation you have to give? HP, platelet, basic investigations, PT, APTT, urine examination for seeing the myoglobinuria. Because myotoxins, you will see the myoglobinuria is here. Or if the viper is there, the muscle injury can also occur in the viper part also. So the CPK can rise up. The myoglobinuria, you test the urine samples also there. So redness of the urine or a cola color type or a red colored urine type is there. So biochemistry of serum, creatinine, urea, and potassium, ECG, X-ray, CT, and ultrasound is a basic investigation you do. If it's a cardiotoxic or a vascular toxic, ECG is useful. And if it's a clotting time is a CT or the patient is drowsy, you go for a CT head or a ultrasound for any bleeding in abdomen for there. So these are basic investigation which has some inference or some useful in or part. Oxygen saturation, arterial blood gas, enzyme-linked immunosorbent assay for confirmation of any venomous part or ELISA for any test. Anti-snake venom. Antivenom is an immunoglobulin. It's how it's prepared. It's prepared from the horse, mule, or a donkey part, or the immunized with a venom. The venom is injected with a non to make that no antivenom from one or more species of the snake. In India, it is a polyvalent. So in the anti-snake venom, I have depicted one diagram also of one anti-snake venom having a Russell viper, common cobra, common crate, salt-scaled viper. So there's no monovalent anti-snake venom. Always a polyvalent. Why polyvalent? Multi snakes venom can be covered with this single anti-snake venom. Okay. So this is way you put your anti-snake venom in 10 vials, mostly 10 vials. The basic of the anti-snake venom is that you take first 10 vials and put it and dissolve in 100 ml and dissolve in 400 ml normal saline and give it in 30 minutes. Okay. Local administration of anti-snake venom is not required. Don't do that. It's not useful. Intramuscular is never done. Evidence of what are the indications of the anti-snake venom administration? You find systemic toxicity, any hemodynamic instability, hypotension, any clotting disabilities like cranial nerve abnormalities also can be seen, local toxicity, or any soft swelling. It doesn't mean that you have to wait for these. If any one symptom can come now, you have to give anti-snake venom. Okay. And what is the for neuroparalytic snake bite? You can give anti-snake venom 10 vials stat. You don't have to wait like a 400 ml or given a 2 hours. You give as soon as possible 10 vials in 30 minutes. If not improved, give another 10 vials. It has seen in studies also. I have seen in that some studies that 20 vials more than 30 and 40 vials can also be given. Yeah, the side effects of the anti-snake venom is also seen, but the side effect is not that much high. That is the improvement can be seen if you have required the more vials can be given. So approximately maximum what I have seen in studies is 30 vials can have given. Okay. So and neostigmine for the nerve improvement for the as a Tendelin test I have explained in the future slides. That the tensilin tests have done, you give the neostigmine, you see the progression of the muscle neurological improvement, and you find that if there's a neurological improvement is there, it means the patient has a paralysis and is improving the when you give the neostigmine or acetylcholine is releasing. It means acetylcholine is present. That acetylcholine is present. You have the it is acting. It is not able to act on the receptors. It is post synaptic. Like, okay, so this is a tensilin test. So for a vascular toxic, you is a two prongs of therapy is there, like a low dose therapy and a high dose therapy. What you do in a low dose therapy, you give 10 vials of anti-snake venom of Russell vipers. It is bolus like a 30 minutes and then followed by 2 vials every 6 hours. In high dose, you give 10 vials as above in a low dose therapy, but in a high dose, you give 6 vials 6 hours. Okay. So this is the I have taken a picture for you. So anti-snake venom, as you see, there's a standard Cobra vaccine is there, zero point 0.6 milligram. It means approximately 0.6 milligram of 6 milligram. It implies that much of venom of Cobra venom. A single bite, how much venom is injected? It's mostly it is average is 63 milligrams. Okay, it has been seen that. It's in a studies purpose. Nobody has calculated personally, but seen in a studies point of view. So, and every polyvalent has a 0.445 milligram of this vial contains 0.45 milligram of anti venom. So you give 10 vials, so approximately for 5 0.45 milligrams. Yeah, according to 10 vials, you give. How long antihistamine can be given? It is not till the things got improved. You can give the anti-snake venom. It is not like the time-driven thing. As a find you think the patient is improving, you can give anti-snake venom. If patient is not improving, then you have to give extra dose of anti-snake venom. How much is not studied. Some has given 20, last 30 can be given. So anti-snake venom cannot reverse the necrotic part. Whatever the damage is done, that is damage is done. Do not reverse the coagulant part. So the things that the damage is done by the venom is not be reversed by the anti-snake venom. It will only reverse the future things. The future will not get damaged. So the anti-snake venom is given. Response to the initial dose of anti-snake venom. If an adequate dose of appropriate anti-venom has been administered, the following response may be observed. Generally, the patient feels better. The things that you see like a spontaneous bleeding is it stops and blood coagulability will improve. The shock will improve. The neurotoxic part, cobra, the nerve part if improves. The nerve conduction. So repeated doses criteria is whole blood clotting time you have to see. More giving for criteria for giving more antivenom. If it is not improving, then you give or deteriorating neurotoxic or the cardiovascular signs if you see. Range of a venom injected is about 5 milligram to 147 milligram. So it doesn't mean that some patients have injected only 5 milligram or some have injected very less. So it is a range of that or more than that also. So what is the adverse reaction of anti-snake venom? Like anti-snake venom, you say urticaria, any anaphylactic. So so it is like an anaphylactic reaction occurs if you give the anti-snake venom. Urticaria, itching, fever, bronchospasm, diarrhea, because it is increasing the acetylcholine part. So you see like these effects. Okay, so parasympathetic mimetic effects can be seen. So treatment of hypotension shock, you give the fluids. Main part, you have to, if the fluids at the part of the improvement, you find that the patient is not improving with the fluids, you have to add the vasopressors. So in pregnancy, you can give safely to the anti-snake venom, you can give safely. Okay. So suspected snake bite. So this is just a chart. So overt bite, if you see history of the bite, you have to ask. Then you have to give as a non-venomous, mostly 70% is seen. Then it's a dry bite or a wet bite or asymptomatic. Symptomatic, then you have to keep an observation for 24 hours. If symptomatic, you have to give the anti-snake venom. So for neuroparalytic, you have to give anti-snake venom and neostigmine. For vascular toxic, you have to give anti-snake venom and you have to give a supportive treatment like IV fluids. And if renal failure is there, then you have to give a dialysis. For myotoxic, muscle fibers are improved, then you have anti-snake venom, supportive treatment, or if the rhabdomyolysis is going on or muscle injury is going on, then you can require a CRRT or a dialysis required. So there's a whole course of treatment in a short way. I know the time that I have taken to explain you all. A part of just the basic knowledge that you have to give is that how that if there's any venomous or a non-venomous bite, you have to admit it. You have to give anti-snake venom, do send in proper investigations, and keep in observation and do ABCs. So this is a main thought of treatment of anti-snake venom and the venomous bite of a management of a patient with a venomous bite. Thank you, ma'am. Thank you, sir.
So thank you for the nice presentation. Participants can unmute themselves and they can ask questions if they have any directly.
I've stopped sharing my slide. It's okay now. I don't have
Okay.
to share now. Yeah,
No,
sure.
no. So I think there are 15 participants. Anybody interested in asking any question?
I think everyone has understood very. I think nobody has understood or something has understood or not. I don't know that.
It was slides were self-explanatory. Wonderful slides.
Thank you, sir. Thank you very much, sir.
So I think nobody is interested in asking any questions. We
Yeah,
should.
I think so. Uh, you say, sir. Anything else you want to tell about your experience, sir? Anything else you want to tell?
Usually patient come to us very late with
Yeah,
mostly multi-organ dysfunction when sets in, then only they come to us at the tertiary center. Primarily at PHC district levels, they're doing good. Antivenom mostly is everywhere it's available.
that's a great part. That's a great part. The antivenom is available in a government sector and every PHC center. That's a great part. That's now.
Exactly, at most of the centers it's available, and
Yes, sir.
even the anaphylaxis with the antivenom, they manage it well.
Well,
So whenever it comes to us, it's only about managing multi-organ dysfunction,
multi-organ dysfunction.
respiratory
Yeah.
support and other supports, so dialysis and all that. So I think nobody's interested in asking any question.
Yeah. So I think the
Yes.
ma'am, Deepa ma'am, the ma'am wants what to carry on or what to do.
Ma'am, sir, We can wait for 5 minutes. Wait
Yeah,
for
sure.
2-3 minutes.
Okay.
If there is no question in chat box, then we'll end the sessions.
Okay.
Sure, sure. Mostly in our center, sir, the what I have seen just in Rajasthan, so peripheries are not that much. I think not evident of that or not improving. But yeah, now they are getting indulged on that. But they have to, if they are not able, they will send as soon as possible to the higher center. This they have got these type of things in their brain now that yeah, something has got going fishy, so we have to send it as soon as possible. If so, these are things that they are understanding well. So this is a great part they are understanding.
Also, this session was meant for nursing staffs. You showed a very good slide of how to immobilize the limb.
Yeah. So
Uh,
that's why I've put it up in that way.
yeah, that was a brilliant slide. Everybody should look into that, how to immobilize. People have misconceptions about immobilization, applying a tourniquet, and when to release. They do not have much conception about, much idea about all this.
Idea about it. Yeah.
They wonder.
Concepts of are not to how
Yes,
to mobilize the
most of
patient from
them,
this way to that way.
yes, most of them gets guided by daily soaps and films. So much
Yeah.
they have
Yeah.
seen
Yeah.
for too long. So that was a wonderful slide.
Thank you, sir. Thank you very much, sir. Thank you.
I could still see 16 participants.
Yeah, I see, but nobody is asking the question, so I think it's okay then.
Actually, normally we are the 6 question and answer sessions भी होता है.
Okay.
तो question and answer session आप डॉक्टर प्रतीक
Yeah,
कोलवल.
I haven't put it. Yeah, I haven't put the 6 objectives.
हाँ तो it's why एक्चुअली वो क्वेश्चन का आंसर चैट बॉक्स में पार्टिसिपेंट उसका ऑप्शन करते रहते देते रहते.
Okay.
So हम ही लोग पूछ लेते हैं, what's the mnemonic
Yeah,
right
we should ask
stand
the
for?
questions.
Okay. Yes, yes, sir.
I think we can ask the verbally the questions to them.
I think
Okay.
you brilliantly summarized the right mnemonic right.
Yeah. So anyone can say the full form of right. Any of the attendee want to unmute yourself and can say the mnemonic how you explain carry no right.
Attendants may raise their hand, so I'll allow them to talk.
Yeah, sure. Any attendees,
Anybody
please.
wants to answer, please raise your hand, then I'll allow them to talk. No one raise their hand. So we can
Yeah.
wait for 1 minute, then I'll end the session. Actually, we record this session and broadcast on YouTube also. So
Okay.
many of nursing staff are going from there also.
Okay.
Okay, thank you, sir. So
Thank
with your
you.
permission, I'll end the session then.
Thank you, ma'am.
Thank
Thank you, Niklesh. Thank you.